Thank you, everyone. Thank you all for joining me up here on stage. Great to have you. Thank you. It's been an excellent couple of days and nice to know that this is the last session. I've got a couple of questions, but I'm sure that the floor might have some questions as well. On the back of my presentation, I'd be really interested to hear your perspective on how do we best engage the patient so they are aware and understand that they're at the centre of everything that we do.
Apparently I'm going first. Yeah, so look, I think, you know, it's this whole movement away from the sort of historical approach that really we saw a patient as somebody we did things to and took them places. And I think for us, we've sort of gone down this whole path of, you know, how we actually engage generally with the community to open the doors. And predominantly that's been through campaigns, and like a lot of ambulance services, we're resource constrained. And so the opportunity to engage in social media as a relatively cheap sort of stream of engagement is one strategy. But also we've been exceptionally fortunate, and we recruited a chief of staff from Channel 7 to run our media. And literally in the 6 months since we've had that person on board, the negative, dare I say, industrially driven critical reports have dropped by half. And so the way that's been achieved is actually by positively promoting our workforce actually out engaged in the delivery of care on a daily basis. And she has a personal KPI that she's put on herself, that she's going to have one ambulance paramedic up on the media, both in the metropolitan area and the rural, every single day. And it's just been quite transformational in terms of the way the community has started to engage with us, but more importantly, what it's also meant for the workforce, who actually feel like the organisation is starting to celebrate their success and their contribution in a very much more positive way. So these things are rarely singular in terms of engaging with the community.
Thanks, Dominic. That's great. That's a pretty impressive KPI for someone to put on themselves. But again, that power of that storytelling, if you're out there and visible and you know, people are seeing those stories every day, that's only going to lead to, you know, good brand reputation.
Yeah, absolutely. And I think from, you know, my own perspective, you know, the people that are getting up and talking about their cases, I remember that there was a particular incident where some children were killed, where a car went into a building, and this manager went up and she said, you know, this scene was chaos. It was tragedy. But the way people came together, the community help, the emergency services, and this is on, you know, the broadcast news at 6 o'clock at night, and the humanity that it brought out and the comfort that the community had, this totally untrained media person talking from the heart. And I think this is, you know, the value of the storytelling stuff that you're talking about, Kate.
Yes, I think we're a charity and also an NGO, so I think that puts a different perspective for us. Very easy for us. In theory, we're less accountable to the government for what we do, but we're accountable to the public. And I think as a charity and a trusted charity, we've got to make even more of an effort to make sure that we're transparent and open. So I think what we're trying to do is we heard yesterday on Tuesday about the county registry and making that available to the public so the public can see how well we're doing, and they know when we aren't doing very well. So it's about building trust and confidence that when we get it right, we're very good about that and we tell them, but when we don't get it right, we're also upfront and honest about that. And I think we've had some good examples where we said, actually, we did get it wrong this time. And people, as you know, people want to hear that honest answer, but also that you're going to learn from that mistake and get on and do something different and better next time. And you know, we're increasingly trying to be transparent, put all our serious incidents on our websites, and have an annual review each year and invite the public to come along and hear what we do well. It's not as seen as a PR exercise, but actually to be open about what we are doing and how we can improve.
And I think that's a really important point, that openness and transparency is actually what builds you credit. Yep. It doesn't have to be through the positive stories. Not everything we do is positive, but it's being brave enough to get out there and own the issue when it is negative, and to be open and transparent on your clinical data as well, and so you can access it on the website. So I think that's fantastic.
I think just quickly, I also think you've got to be mindful. We have to be mindful that our staff are watching these stories too. I remember Martin and I used to work together in London, and just very quickly, but for years and years, when we went on the media, when we were absolutely hammered workload-wise, we'd go, "Oh no, we're doing fine, we're doing really well," and we know no problems. Oh, we're all. And then I got a senior job, and the media came. First thing they would come ask me a question. I said, "Yeah, we're struggling. We really are struggling." That was the best thing I ever did, from a staff's perspective, because it was the first time that anyone had admitted that we were struggling, to not only to the public, but to our staff.
Because that's about authenticity in leadership, that if your staff are hearing a different message that you're putting out externally, what are they going to think internally when they're the ones that are having to front the community every single day?
And I guess from the CAA perspective, obviously we're not a treatment provider, but we found that the use of patient stories, particularly in the area of out-of-hospital cardiac arrest, has really enabled us to sell the message about Restart Our Heart Day. It really pulls the strings of people's hearts when they listen to survivor stories. And equally, in our work we're doing with all the services in the mental health space, having staff who can be extremely honest and upfront about their experiences and how they've recovered from mental health episodes has been particularly helpful in us promoting the strategy.
That's great. Excellent. I just want to ask one more question, and then I'll open it to the floor. Where are the touch points? There's obviously a lot of touch points in the patient's journey with ambulance that you think that we can, more positively impact their experience. What would that look like?
I'd probably answer that in two ways. I think the touch points are actually in how you pre-educate the community to understand, but I think there's actually the second part to that is I think there's a lot more we could be doing. I think we engage in a fairly transactional sort of way. We have an issue, we have a campaign in some way that we sort of try and address it, but like a lot of the community, they only sort of engage with it when they actually need it. So I don't think we're doing that particularly well yet. But one of the things that we've just started doing, we're doing a pilot on the back of the pollen thunderstorm about advising callers of timeframes for cases that where we determine that we're going to be half an hour or 30 minutes for a medical. We go through MPDS and determine it, and now we're actually saying, basically on the information you've provided us, an ambulance will be with you in the next half an hour or next hour. Now, interestingly, out of the as of a couple of days ago, they'd had 840 odd patients that they'd actually advised the time frame. They'd only had 18 people query it. 18. And I think that's fantastic, because I actually, after reading that report, was really interesting to me, because I think fundamentally it goes to an issue of patient consent and being respectful of the fact that they can make decisions that, well, if we're not going to meet their needs because we're not going to come for an hour, would they and can they make alternate decisions? So I think going back to that, are we being reasonable in our dealings with the community? I think this is a really, really interesting direction to go.
Yeah, so that's exactly right, Dominic. That's putting the decision-making back in their hands, giving them enough information that is empowering them to make a decision whether to wait for an ambulance or get themselves to hospital. So, you're never going to get complaints if you're actually giving them enough of that information to make their own decisions.
Yeah, I suppose we have to remind ourselves that on average a person uses the ambulance once every 12 years. So to expect them to remember when you dial 111 or 000, what to do and how to do it and what you'd expect to get. And we've seen that from our own rollout of the nurse, the triage. I think Tony could talk well about that, but in terms of just the patient experience surveys that we do regularly, and despite, we've done a huge amount to sort of educate or advise, but there's still people's expectations are, I dial 111 to get an ambulance, and particularly if I'm going to pay for it, and particularly if I'm a member of your subscription scheme, because I expect. So expectation management is always an issue. So I think the final point, we've got 19,000 people across New Zealand involved in St John. They're our best advocates. So let's make sure our own people are saying that they've got the right messages to give out, let alone to the public, but ourselves.
And I think from the CAA perspective, we're seeing across all 10 member services a real focus on the patient being placed at the centre of everything we do. Traditionally, we've conducted an annual survey on behalf of the sector, and it's been very patient satisfaction oriented in the past. Last year we changed it to a patient experience survey, and after listening to Paul and Emily's presentation this morning, I think we're going to be looking at it again, because with all the work that's happening in the sector, putting the patient at the centre of everything they do, we need to be asking the right surveys and the questions so we actually see the benefits coming through.
Have people on the floor got some questions for our panel this afternoon?
Hey, how you going? My question's regarding consumer engagement. Consumer engagement's obviously a fairly big focus of healthcare these days, to the extent that there's a national safety and quality healthcare standard, particularly dealing with that. I guess one of the questions I have is, for the chief executives, do you engage consumers dealing with aspects of service design? How have you actually done that, and what are the challenges you've found along the way if you've proceeded down that road?
I've got a PhD in making sweeping statements, so I'll be careful what I say. But I'm the only doctor that's not got a degree. And some of the, so I'll be a little bit cautious, unusually for me. Having come from the UK and arrived in New Zealand 6 years ago, back in New Zealand, I was surprised at the comparison in terms of what's expected around consumer engagement, because basically we don't need to do any. We can change it. We can change our prioritisation system. We can stop sending ambulances. We can do anything we want. We don't have to engage. In the UK, it's very, very different. You can't do anything without engaging. And I think there's a middle ground somewhere here. And so we're probably at the other end of the extreme. So, and maybe tell me if I'm wrong, Tony, in terms of our normal, but we don't have to do the engagement. I think certainly with the rollout of something significant, like our 111 triage or clinical hub system, they were absolutely right that we tried to do that, and particularly health professionals too, because we can't forget them, because they need engaging in some of that. So I think in the future, and we've struggled we've got a clinical governance committee where we've tried to bring consumers onto that, or a consumers council, so, and then we have discussions around, well, how do you get someone, how can you have one person or five that can really represent the public, really? But you've got to start somewhere and do something. So I think we're on the journey, to use the euphemism, of getting to a position where we do really actively engage in service change. We should be doing it. We need to do it. It's the right thing to do.
Yeah, thanks. I tend to agree with that. There's a way that, considering we disagree so much so often, no. But I do think that really there's a difference between engaging with the community and meaningfully engaging with the community. And so, yes, to the extent that we try and make sure that we've got, people that sit on different committees and things like that, that's sort of if you're coming from the tick the box point of view. I think one of the things that our team did particularly well was a really difficult concept to sell to the community around our superstation model, and what would that mean? And there was quite a strong pushback that was fertile ground for the community to become very concerned on. And the teams went out and they engaged primarily through the local councils to access marginalised groups within local communities and actually engage with them. And they had days where, they would set up for they advertised in the paper and they would bring community members in and they gave them full briefings on what the superstation model meant for them, which was, quite frankly, absolutely nothing. Dial 000 and we'll come just like we did yesterday. And but it's a simple thing to say aloud. But if Sydney has a lot, and a lot of the communities that were impacted by the superstation model were immigrant communities, English not as a first language, and it was really, really important to genuinely, meaningfully engage with that group of people. To the fact that there's very little talk about the superstation model anymore, simply because of the way that the teams actively got out there and engaged with the community. So it was really quite positive from that state.
And I guess just to add to that, last night we recognised South Australia Ambulance Service for its accreditation award. And anybody who's started to tackle that piece of work will recognise that one of those standards is heavily focused on consumer both engagement but consumer input into design of service and evaluation of service. So I know that SAS struggled with that to start with, but I've found that the input has been extremely beneficial. And I think as other services take up those standards and start on that journey, we probably need to work collaboratively together to assist in some way.
And I'll just add in quickly at Ambulance Victoria, what we've been doing over the last 12 months is actually going and holding community forums in our regions. Now, this isn't based on we've got a new super response centre or we've got something in your backyard. This is based on come in and just have a talk to us. Come in and tell us what's working in this area. But it's targeted to people that are outside of the health services or outside of that they've had a service dealing with us in the last 12 months. How we did it was we targeted out through our membership scheme. We emailed people that we knew were in that region and said, we want to hear from you. Please come down and join us. And we've also created an online two-way engagement website called Better Together that they can come on and they can talk directly to us. So it's something that we're, I think, testing in that we're not, engaging for engagement's sake and ticking a box, but I think, again, we're on that learning journey.
We've heard a lot about equitable access during the Congress, like particularly from Lance. As chiefs, have you taken anything away from that and to your own services?
I think, again, we're going back to the previous roles. I think certainly in other parts of the world, which remain nameless, there's an expectation around equality impact assessments for every service change. So again, if you're rolling out a clinical hub, you wouldn't do that without speaking to groups that could be affected by that where English isn't their first language, for example. So, and we haven't done that sort of stuff, but there's absolutely a requirement in the future, particularly as we look at more service change over the next 3 to 5 years, that we consider the impact on different groups within society. Deprivation, different issue perhaps to English second language or not a first language. So we've got a lot more to do in that area. But I think our priority at the moment is to satisfy ourselves that we are providing an equitable service where it's within our control to do that, within our own resource availability. And at the moment we're very much early into that.
Yeah, I think that's a fair point. I think in a lot of ways, one of the things that ambulance services have as a strength is pretty much on the southern border we can deliver precisely the same care as we can deliver on a northern border, and pat ourselves on the back for the consistency of that care. What's lost in the middle of that is the fidelity that it all assumes that all patients come to the service equipped in the same way to receive the treatment that we want to give to them. So I think that's true. I think apart from local initiatives around things like, Indigenous communities and kind of like I was touching on before, dealing with immigrant communities from a non-English speaking background, I think it's quite limited. And then you get into the whole idea around, standard scope of practice versus advanced clinical care versus a broadened scope of practice. And, that perennial debate that you have is what's the right level of exposure that you need. So on the one hand, you've got the debate about providing advanced clinical skills, and you've got the other one about providing a safe practitioner who's experienced, current, and keeping up the exposure. So it's a challenge, and I would have to agree with you, mate. I don't think we particularly do it that well either.
Just one other quick examples. In St John, we have 1,000 caring callers. These are by and large elderly men and women in the community who provide telephone support and companionship over the phone to vulnerable elderly people anywhere in New Zealand. So we've got 1,000. We've got one of our board members is Asian. He's been with us a year. Unbelievable man. He's a real champion for the Asian community. And in the past few weeks, he's recruited 60 caring callers from the Chinese community to provide support to the Chinese community where English isn't their first language. So it's fantastic. And it's just one person, one example, but it's a really inspiring example.
And from the CAA perspective, we have a role in collating best practice and sharing that within services. And we're in this really fortunate and unique position where we hear the best of everything that's happening in services. So we have a responsibility to share that, particularly where we see models work particularly well in those rural and remote communities. And I think paramedic registration is going to be an enabler for the sector to do even more and take up the challenge that Dr. Lance O'Sullivan provided to the whole group yesterday.
Funnily enough, I actually think my former jurisdiction, Tasmania, is probably doing it better than a lot. The police commissioner down there was very motivated around multicultural communities, and he invited me on to co-chair a committee engaging with Multicultural Tasmania. And part of the work that actually flowed out of that was documentation for not just around how the control centre would engage with communities and having access to to interpreters, but also they produced a whole range of visual guides and prompts for a range of different languages, so that when the paramedics went out, they could actually help to go through, particularly for people from a non-English speaking background. So I think Tassie was actually doing it reasonably well in that regard, and it was because there was a much bigger push than just the ambulance service in making sure that we had appropriate services.
Great. I think we have time for just one last quick question.
Hi there. Dominic made a comment earlier about the tendency to objectify patients. And it's likely that the history of that is stemmed in when that was our only protective mechanism. Now that we have a lot of other more effective strategies around building resilience and our emotional flexibility, do you have anything to say around the piece of saying, we're trying to tell paramedics to engage with staff in a new way, which is essentially counterintuitive to what they've been doing for the last 130 years. But saying it's okay to do that because there's actually now a whole bunch of other things to keep you safe. And that's probably kind of existentially more of a transition than we may realise.
So getting the nub of the question was...
Sorry. So I guess the question is, how do you tell staff to do something that may be counterintuitive to them, because they've spent the last 30 years on road referring to somebody as that's the fracture or that's the STEMI, and actually call them by their name and talk about them in a much more intimate way, when they've been they've had that kind of objectivity as a protective mechanism. So in their head they're thinking, if I don't get close to the patient, I'll be more resilient by not seeing them as a person. But now we need to see them as a person, and I guess how we're going against something that's been culturally ingrained, and how we move through that transition.
Okay, so the broader question of how do you make cultural reform is, I think, what I heard there. This may sound twee, but I totally believe it. Be honest and role model it. And New South Wales is on a huge cultural journey, and myself and my deputy have committed to, we're running these things called wellbeing workshops, and we're bringing every single staff member in New South Wales together. And we've been doing that sort of since March, early in the year. And it'll be at least a 2.5-year program, and my deputy and I have committed to attending the first session on the first day for the entire next 2.5 years. And we have a presentation we do about culture, and it's a straight talk. And we basically, without fear or favour, talk about the impacts of negative behaviours and ultimately what that has on individuals. But of course, if you're having bad behaviour amongst yourself, how can you give a positive patient experience? And there is absolutely no doubt. So it's evaluating exceptionally well in terms of the fact that this is the best opportunity that we as leaders get to stand in front of our workforce and articulate clearly and honestly what it is that we believe are the expectations of anyone delivering care. And I think that that fidelity of the one-on-one, where our entire workforce, I mean, we're sort of 4,500 plus people, can see the two most senior leaders saying, this is what we value, this is what we think is important, and you are empowered to call out bad behaviour, whether that be you just didn't speak to your patient in the right way. And one of the things I actually say to them, it's actually okay to turn around to someone and say, hey mate, we just don't do that here anymore. You know, and I think that that is actually quite contagious, and I think that that is the best chance we've got to ensuring that we have a really positive patient experience, is that our workforce have an equally positive experience every day they come to work. Does that answer your question, Buck? Yes. Yeah.
That's good. Dom's answered it. That's great. Thank you. I haven't got much else to say except to say that it's a very complex issue and can't be answered properly in a couple of minutes. But Dom's answered it well. I think, you know, the whole issue around, as we know, compliments and complaints are for the same thing in reverse. People write in and say the staff were fantastic, they were compassionate, they kept me warm, they listened to me, they were, you know, and people complain about exactly the opposite. You know, so how you deal with that, and the whole generational issue, and the whole cumulative effect of being in the service for a long time. And you know, very quickly, I spent quite a lot of time on the road. Towards the end, I'd had enough. You know, I was irritable. I'm always like that anyway, I suppose. But I was irritable and impatient. And now, if I go on a shift now, I'm nice as pie. I'm older. I don't do it very often. And I know it all about what people expect. So it's a very complicated area, and I think if we can crack it, it'll be the biggest and best thing we can ever do for the ambulance service.
And just to add to that, Buck, I think the universities have a key role to play here. We need new graduates that come out with the right approach to patient care, and to do that, we need to make sure they get the right clinical placements with the right clinical mentorship early in their career, so they don't develop these habits.
So that's all about putting the patient at the centre, which is a nice note to end on. I'd like everyone to thank our CEOs this afternoon. Thank you.